Hello, I'm Balázs Komoróczy, and I would like to introduce myself and my PhD topic in a few minutes. I'm a resident doctor of the Obstetrics and Gynaecology clinic at the Semmelweis University, and by my PhD topic, my vision is to prevent adverse pregnancy outcomes such as preeclampsia and preterm birth. And to this, we would like to set up a reliable screening model for pregnancy complications, which can lead to preterm birth. As our specific goals, we performed a meta-analysis and a systematic review on the topic of the optimal dose of aspirin. And simultaneously, we also started a project for screening for spontaneous preterm birth in singleton pregnancies. On my first topic, what is a really good news for all of us that we already submitted this paper in August 2023, wrong date on that. So just to sum up the background for this, the preeclampsia, which is a life-threatening complication of pregnancy, the incidence of preeclampsia is approximately 5%, and with low-dose aspirin initiated in the right time in the early pregnancy, between the 11th and the 14th week of the pregnancy, can be prevented. But however, we know a lot of preeclampsia prevention. The optimal dose is still not well defined. And to answer the question for finding the optimal dose of low-dose aspirin, we set up a clinical question, and for this we set up a so-called PICO, which we investigated pregnant patients who received aspirin and compared to placebo. And for the outcomes, we also examined preeclampsia, preterm birth, intrauterine growth restriction, and other fetal and maternal adverse outcomes. After the systematic search and flowchart selection, 62 eligible texts were analyzed, and for this 8 outcome we had our measurements. I would like to highlight those outcomes which can be modified significantly with rightly initiated aspirin prophylaxis. As you can see, preeclampsia, intrauterine growth restriction, gestational age, the birth rate, and perinatal death can be the rates of the adverse outcomes can be significantly reduced. For preeclampsia, the overall risk ratio is 0.76. And we found that only 75 and 80 milligrams of aspirin were effective. For intrauterine growth restriction, we found that 75 milligrams and 150 milligrams were also effective. For gestational age, we found that if we administer the patients 100 milligrams or 0.5 milligram per kilogram aspirin, the gestation can be prolonged about 2 to 3 days. For birth weight, also 50 milligrams, 100 milligrams, and 0.5 milligram per kilogram can be effective. As a really important outcome, perinatal death, we found that 81 milligram of aspirin is effective for it. But overall, if aspirin it was initiated so overall, any doses of aspirin were initiated, the risk ratio showed significant difference. Just a few recap. If we start aspirin prophylaxis in the following outcomes such as peritoneal preeclampsia. If we treat 1,000 women, 10 fewer cases can be counted. And also you can see the numbers that for intrauterine growth recession 9, and for perinatal death is 5, the same number. Our strengths as that this was the first dose response assessment of the aspirin prophylaxis, and we also concluded that there is by the analysis there is no dose dependency between the administered aspirin dose and the adverse outcomes. Also, a great strength of our study, as I know it's the biggest study in this topic, and we almost investigated 50,000 pregnant patients. Our limitations are the heterogeneous population and some differences in outcome measurement definitions. Just to conclude that I would like to emphasize that aspirin have prevent preeclampsia in high-risk patients without elevating the fetal and maternal risks. But also I have to conclude that there is no clear correlation between the dose of aspirin and its effect. For clinical implication, I would like to implicate that for all the benefits, at least 100 milligram of aspirin is indicated. We submitted our manuscript to BGOG 28th of August, and we are waiting for their response. Our second topic is screening for spontaneous preterm births and singleton pregnancies, which is crucial because the incidence of preterm births is nearly 12%, and it's a really hard challenge for obstetricians to screen for preterm birth. And we would like to apply a combined screening model of the cervical lengths measured and the obstetric history for prediction. For this, we will investigate pregnant women with singleton pregnancies, and we will measure the cervical lengths on the second trimester ultrasound screening. And if the patient has shortened, the patient with shortened cervical lengths will be compared to normal cervical length patients. The outcome, what we measure, will be the preterm birth. We would like to involve as many patients as we can, but of course some exclusion criteria should be made. And we will divide the patients for two groups, normal cervical length group and shortened cervical length group. And our primary outcome, as I said, will be the incidence of spontaneous preterm birth. Just summarizing my two topics. My first topic was submitted to the BGOG on August 2023, and we are still planning our second topic. Thank you for your attention.
If I could start, and I understand we don't want to torture you, but we need to understand what is happening in your progress. And of course, just like in any other progress reports, that we want to support you, to help you to do that better. So the first question is very simple. In your presentation, that you said that you selected 62 presentations, and then your paper list actually 59. So what's the difference?
Yes, thank you for your question. The big difference that it's 29. It's 59. The actual number is 59, but I wrote it. I wrote it wrong on the paper because afterwards we eliminated 3 articles from the draft, and I just did not make the correction on the.
What was the
PPT
reason for
document.
that? I mean, just
Moving
3 articles.
Because of in one article, that's because it was not an RCT, because we only investigated RCT studies, and from one article from it was not an RCT, it was a retrospective study, and the two other was secondary analysis of another study which was already involved in our analysis. That's why we removed these 3 articles. I just didn't correct it in the PPT, and I insisted to it.
Well, the other question, which probably will be kind of asked something similar by others too, that what do you think about the mechanism of action? I mean, usually a drug, affects certain functions in a dose-dependent way. Now you show that this is actually not dose-dependent. But there are some doses when you get response, some others when you don't get. So what is actually in your hypothesis behind this? Why is it happening?
Thank you for your question. Or my hypothesis behind this is that which one limitation of our study is that we wanted to examine as many patients as we can for big data, but the inclusion criteria of each study were different. In some cases, they were examining singleton pregnancies. In some cases, they were investigating Gemini pregnancies, twin pregnancies. And both, and in some cases, not only high-risk pregnancy were involved in these studies. So today, only for high-risk pregnancies, for preeclampsia, only high-risk pregnancies are in high-risk pregnancies. The aspirin should be started to administer between the 11th and 14th week, but in some of the studies, some of the RCTs did not started it in this interval, and some of the RCTs did not make the inclusion criteria well. I think that's the heterogeneity of the population and the initiation time of aspirin.
Yeah, but then your title says that this is something like the optimal dose for aspirin, and then in the meta-analysis, which in the forest plot which you show in the paper, is actually the dose of 81 has no effect.
Yes,
and then you just showed us that in actually prenatal death, the 81 is the only one which was effective. So it looks like that is coming up and disappearing, coming up and disappearing, depending on the sample size. So one worry about this is that the 81 dose is actually given in very, very few studies, if I'm right.
Yeah.
Am I right? So it is really hard to say that you could find the optimal dose. I mean, what you could find is a kind of no dose dependency. So Again, I'm a little worried about this. I know that you had a kind of time pressure on one side, but on the other side, you may get actually rejection by the journal. I mean, that's quite possible. And then you have to work quite a bit more on this.
Yes, thank you.
My question is related to the theoretical background of the first project. What do you think? What is the theory behind using acetylsalicylic acid to prevent preeclampsia?
So for this question, I would like to answer it, but I think right now I cannot answer it.
Are there any other NSAIDs that can be used for the same purpose, or this is the only one that could work?
From NSAIDs, aspirin is the only what can help. Some combinations with low molecular weight heparin are also examined and investigated, but we in our study we did not investigate these combined groups.
So this is related to the effect of the thrombocytes.
Yes.
So this is not related to the antiphlogistic effect itself.
I can't answer the question.
Okay. I also think that claiming that more than 100 milligram aspirin is the best choice, based on what I see here, I would not say. So it's clear that there is a difference between low and higher doses, but I would not say that 100 milligram is the difference, which is the effective, and below 100 milligram is not enough. This is only advice, and the question is that is there any link between all these outcomes and preeclampsia? So, or
yes.
all the other outcomes are or might be related to preeclampsia.
Exactly. Preeclampsia is strongly related to intrauterine growth restriction, also preterm birth, which in our study we did not separate iatrogenic and spontaneous preterm birth, but in case of severe preeclampsia, preterm preeclampsia, of course, the only option to solve the problem to perform an induced preterm labor and preterm caesarean section, and also this will lead to shortened gestational age and shortened and lower birth rates, and also it will also lead more perinatal death and neonatal intensive care unit admission, of course. So somehow all of the outcomes are related to preeclampsia. Intrauterine growth restriction not only related to it, but it can be also in the definition of preeclampsia.
Okay, and my last question: what is the level of evidence between the critical or cervical length and preterm birth? Because the aim of your study is to analyze the link between these two. But are there good trials to confirm this association, or what is the current status of the science?
Or one of the leading societies, thank you for the question, one of the leading societies, the Fetal Medicine Foundation, has already set up that there is a strong correlation between the shortened cervical lengths measured before the 26th week of the pregnancy and preterm, spontaneous preterm birth. And by this study, we only would like to strengthen this, and we would like to try it in Hungarian population. It hasn't been shown that it has anything to do with ethnicity, but we also try to strengthen this.
You have no suspicion that Hungarian cervix length would be different than other ethnicities, I assume? So probably the same?
Probably the same, yes.
Then have you thought of like checking like multiple different lengths, or do you have only like one cutoff that you want to use? Do you want to look at those length dependency?
Yes. It has been examined, the length dependency, and so in 5 millimeter ranges it was it was investigated, and it has been found that below 26 or 26 millimeters the pregnant patients had higher chance for preterm delivery, but it's only had significant effect before the 26th week. Also, but
and regarding the statistics of the first project, probably you'll get more comments. But if I understood it well, then when you do a pooled analysis on all of the concentrations, then you see effects consistently.
Yes, exactly.
But whenever you do a subgroup analysis, within subgroups, you see basically no effect. Sometimes you have like one, sometimes basically nothing.
Yes.
So actually, I'm just wondering whether you can even say anything about these, because basically you have no significant effects within these subgroups. So I think it's just difficult technically to say that something is better or worse if your overall effect cannot be recapitulated in almost any of the subgroups. So my conclusion would be even more cautious than previously. Maybe I would just say that you can't determine whether any of the doses would be better or worse. That's my assumption. Would you agree?
Thank you for your assumption, and I think it's the good way to look at it.
So maybe you said that above 100 milligram recommendation from your side. So maybe that's why, because you just can't tell, and then you want to be sure that you just give it high enough dose.
By your analysis, yes. So by your analysis, you're right. There cannot be so optimal dose cannot be defined. Yes. Thank you.
So my question would be regarding this part of presentation as well. One of that you mentioned that you could not really find the dose dependency, and you try to explore it with a meta-regression. But have you considered including possible confounders to this meta-regression? For example, I don't know if the age of the examined populations differed in the different studies, and maybe by chance in one subgroup all the women were older, the mean age of all the women were older than in the other subgroup, or you did not consider other confounder variables.
Thank you for your question. When the data was collected, we collected as much details as we could about the patients as well, and most of the studies gave a big range for maternal age in your case, what you mentioned, and that's why we would not be able to differentiate it from young to older.
And one more thing that I see that are 7 or 8 dosages that were used, and 1 or 2 are significant in each case. Have you tried to categorize it into low and high dosage and compare only that, I don't know, below 80 and above 80 milligrams of the dose, and maybe that way you will get a more robust result that, for example, below 80 the effect was not significant, above 80 the effect was significant. So maybe I would go this way to not look at these small categories, but rather try to make more robust categories.
Thank you for your suggestion. We did not separate it. We only did this separation in case. No, in this study we did not do this separation. Thank you.
And one more thing, it's really a kind of a theoretical question. Why did you decide to use the risk ratios? Why did not you use the odds ratios, for example?
We examined only RCTs in our studies, and for this and for the to determine the effect, we decided to use risk ratios on yes or no question, in yes or no questions, of course.
Thank you.
Maybe I have one more question or two. I actually agree with the suggestion that maybe you will have some sort of power as well if you combine the doses. Actually, you could just do a cutoff of like at 100, below 100 and above 100. And at least your conclusion that maybe you should give 100 or more could be more valid. So it could be easily tested, and you just have to shuffle the table and send it to statisticians. So it's not a lot of work. It's not a bad idea. And my other question would be, you said that actually you're only using high-risk pregnancies. Based on this data, would you ever consider giving aspirin to low-risk pregnant women? Thank you.
Based on these data, an aspirin could be administered to any of the patients, because we evaluated the most feared side effects, like placental abruption and peripartum bleeding, and in both cases we did the incidence of placental abruption and excessive peripartum bleeding did not leave the level of significance. So based on these data, every pregnant patient can get aspirin safely.
I have a question anyway, but you just made me to comment on this, because I strongly disagree with promoting a drug to a normal scenario like a normal pregnancy. Let it be aspirin. It may be a benign drug, but it's still a drug and it may have harm. So I would be very careful with that recommendation, because you have no data at all to support that. And I also agree with all the comments on you have to tone down your conclusion and if there is any message in that. But anyway, what I picked up on your forest plot, that the publications were mainly published in the early 1990s. So the earliest one is from 1990, and then the interest somehow faded away, and the latest one, if I'm correct, is coming from 2018. So basically nothing for the last 5 years.
For this outcome, maybe, but for preeclampsia, we have recent studies as well from 2021, 22, and 23 as well.
Yes, you're right. But this means, to me anyway, that for some reason, the interest of the obs-and-gynae community was reduced, if not lost, in that particular field. And I'm aware that, for example, in the Netherlands, gynecology is really a pulling research field. So they produce a lot of papers and of very high quality. So what is in the guidelines regarding aspirin?
The guidelines suggest for the dose, you mean, or for?
Yeah.
For the dose?
And this is another question, that because it is such a long span of collecting articles, 30 years you are collected articles, whether the administration regime was the same in all articles, dose length, obviously the dose not, but the length and when to start, when to stop. So it's because that could be a huge confounding factor.
Yes. It was always the most interesting question during the aspirin supplementation, but it has been suggested that between the 11th week and the 14th week, it has to be started. After the 14th week, it does not have really any significant effect on pregnancies, and but it can raise the incidence of placental abruption, and that's why it's not safety anymore. Regarding to the dose, today's recommendation recommends 150 milligrams per day, and suggests that try to raise it in clinical circumstances 162.5 milligrams, because our article didn't find any dose dependency, but there are articles which can define dose dependency. I think the most important question is in the involved patient. So what is the inclusion criteria for the patient? If and that is the most crucial question, to find who can benefit the most from aspirin prophylaxis during a pregnancy.
I have a research project for you.
have you heard of this term? I read an article, an Obs and Gynae article a few years ago, and that was a huge Scottish survey on, I don't know, tens of thousands of pregnancies. And they reported that elective cesarean sections are basically programmed premature birth. Have you heard that?
I've heard it, yes.
And there is a cognitive effect of that, and that this article shows some cognitive effect on the children later on. And I mean, in Hungary, if I'm not mistaken, especially in the well-off part of Hungary, like Honvédkórház, the elective cesarean section is above 50%.
Above.
So, I mean, this is a fantastic population to do some kind of an observational study on just for you to consider. If this cervical length story doesn't work out well, then, you know.
Thank you for your presentation. I have one question regarding acetylsalicylic acid. You have mentioned that there were no increased complications regarding the gestational period, but I'm concerned about one, which is gastroesophageal reflux and ulcers, because it has been shown on a healthy population that if acetylsalicylic acid prophylaxis is administered, then the risk of gastrointestinal bleeding, even in small doses, prophylactic doses, increases tenfold. So what do you think about the, do you have any data on these increased complications or these risks?
So there is in our study, there is no data for gastrointestinal bleeding, but you might consider this that that the state of pregnancy is a thrombogenic state also. So it might not be as if we administer aspirin, it might not be as dangerous as for non-pregnant patients.